intervention. This is about vertebral augmentation, complications, and troubleshooting. And see, we've been reading from our childhood, prevention is better than cure, and this holds true even in adult life also. And see, with the prevention we really know how much is the role of prevention now. And see, when you say, don't manage a complication, prevent, and prevent, Am I audible? Am I clearly? Am I visible? Swati?
Yes, sir.
All good. Okay, fine, friends. So I'll go ahead quick with that. So the whole idea is, this is about the procedure complication. When you start a new procedure, the new surgeons are always dangerous surgeons, they call it. The number of complications always more because of the learning phase and all, and it's a hit and trial methods. But never be over adventurous, because in a vertebroplasty, if you do a mistake, you have a paralyzed patient going home, and your practice is gone. You cannot do any more vertebroplasty. So whole idea is, do under proctorship, do under guidance and all, and when you do more and more vertebroplasty, the number of complication reduces down there. But thereafter, any complication which happens is to do with the complacency, when you get more complacent with time, so then you have this complication coming. And we even do have complication, and always relate to the complacence, not lack of knowledge or skills. This was a good paper in 2003. The complication 1100, 16 patients, 1100 procedure performed, and they found the most common PMA leakage was the complication which is around in the paravertebral vein, and then paravertebral areas, tissues and veins, and intradiscal leakages 8%, and PMA leakages into spinal canal only 0.8%. And the results of treatment did not differ between patients with or without any complications. And of the 104 patients, they did chest X-rays. Only 2 patients had a pulmonary embolism without any complication, without any clinical significance. And the one patient had a PMA leakage into the spinal canal, which required kind of an open decompression. So be ready. There may be a situation you might need to do some decompression if something goes wrong. In my about 700 plus vertebroplasties, none has been gone for a open surgical decompression. But yes, you should be ready for that. So in conclusion, PVP is effective to decreasing the level of pain in compression vertebral fractures and complication rates. This is the study, and I'm quoting the results. Complication occurs in almost half of the patient, but that is most of the cement leakage is inconsequential, and none have had a very serious complication. And this was the given suggested threshold for complication or different complication. We should know the complication, what all can go wrong. We should be ready for that, and accordingly, kind of prevent that. Until you know what can go wrong, how will you prevent it? The idea is, there's a transient neurological deficit in few patients, and there is a transient, by the way, and more so neoplastic. Dr. Alexis gave a wonderful talk. This is one of the top of the line talk today, and I was very, very happy and impressed that I could attend it. And this is where something can go wrong, but you are ready, prepared, because it's advanced palliative care and end of life care now. And other 95% patients you are giving a kind of a pain relief. And then there's a permanent neurological deficit is so low, otherwise in osteoporotic ones, in neoplastic, yes, it can happen. Again, should be avoided as much as possible. And then the rib fractures and head fractures, when you're going a dorsal level, you're doing the vertebroplasty, I'll explain you. And then allergic reactions to dye or sometimes the liquid monomer can happen. Be prepared. Infections rarely can happen if you are doing surgery in a righteous way or sterile ways. And then you have a pulmonary cement embolism. This is to be avoided. You can't do much about it. There have been some studies where the cement has gone into pulmonary circulation, even to the heart, and then they had to kind of do a interventional cardiology management. I'll show you those slides again. And hemorrhage and vascular injury. There has been a case of epidural hematoma causing compression, had to be decompressed. So please be very careful, and you have to look at that. Death is 0, yes. But there has been a case, this 2003 study, there has been a death because of pulmonary embolism, acute pulmonary massive embolism. Again, a novi person, and doing something wrong. And that's where it really started. Vertebral hemangiomas, too much has been talked and nicely told, and this is where you kind of cement them, and you just see it's aggressive hemangioma. You kind of put a thick cement, you block the feeder vessels first, so that the cement does not get into the spinal canal. You have to be careful, but here you have to create a support structure, because you do only painful vertebral aggressive hemangiomas which are dangerous looking, not otherwise. Yes, vertebroplasty has been extended, normally we do it for all those fractures, but it is done by the side of the surgery, even to assist surgery, open surgical techniques, because when you want to put in a screw, the screws, they don't hold well. So you have to, either you have a cemented screws, and you can put those cannulated screw cement, or you put a cement first and put screw over that, like it has been shown today. And lately they have doing through a Camden's triangle. I'll show you one study, the Camden triangle approach for percutaneous vertebroplasty. And this is the new thing which is coming. Suppose you don't want to go through the pedicle. Pedicles are narrow, pedicles are fractured. You can go in a Camden's approach, and just like you do endoscopic discectomy and do the procedure thereafter. Now this is the patient. A multiple surgery has been done. Vertebroplasty, some semen leak in the paravertebral vein, and another vertebroplasty, another level, and then some fixation. But nothing is going right. You look at this posterior vertebral margin, and semen is lying in the vertebral canal. Now this patient is having a big problem, pain and problem, and due for another surgery. So I was asked to give a trial of stimulator for the pain point of view. See, gallbladder was kind of intact, and patient was able to walk, but with a big pain. So we tried a trialing on this, but it really didn't work well for the patient, and patient had to go for another very big surgery. This latest thing which is coming in, suppose is there is root irritation because of the cement, or because of the retropulse fragment, or because of any other reason, and this DRG stimulation has come in a specific mononeuropathic scenarios, radiculopathic scenarios, and they do very well in such scenarios, because you can't do reversal of the cement now. There have been patients who had habitual fracture because of the severe osteoporosis, because of pathological osteoporosis, not a patient's fault, and they keep coming to every 6 months or 1 year with the new fracture, and they're so confident of the lasting relief from the fracture treatment, and this is the beauty of the procedure. But remember, this patient came for vertebroplasty. There are few levels of vertebroplasty has been done, and when I was about to do vertebroplasty, got a bone scan done sometime, and I found a hot lesion. This is a rib now fracture which is there. So you have to do a paravertebral block instead of doing a cementing in the vertebra. Yes, understand. This patient had a 1-level fracture, didn't go for vertebroplasty, vertebral plana very typically. Now his patient has got 2-level fractures. Now this is the worst thing which can happen to a patient, because there is already flexural deformity, sagittal deformity is there. There is a loading going on anterior axial, loading is going on anterior column, and they tend to collapse more so. So if I find a patient who has got anterior column gone, and another level coming up, I tend to put in a cement, because there is already an unstable thing and there is a loading going on, obvious loading going on. X-ray alone is not enough. You are not going to cement this, you are not going to cement this, you're going to cement this, or you're not going to cement this, you're going to cement this. So one has to understand, X-ray is not enough, X-ray may be fallacious, and never ever do vertebroplasty just with the X-ray on. Must have a CT or an MRI again with you. Again a very fresh one. And this is a fracture in there, and you're trying to kind of think, okay, let's see conservative, and in 20 days time, there are dates here, 20 days, is May 12th and this is June 6th or so, and this is a collapse with the retropulsion, and there's a posterior cortical dehiscence, and this patient, by the way, has got another lesion. So you're not going to treat this only, there's another problem which is lying in there, and you have to treat them, because it has happened number of times. Just doing a cement, because the acute problem is this, but this again is giving trouble to the patient. So think wholesome, and always get a stir MRI, because then it tells you what is an old and what is a new fracture, and you have to treat the new fracture and leave the old fracture alone if it really doesn't merit any cementing. Sometimes bone scan is helpful. If you want to really find painful lesion, I told you, it will tell you distal lesion, multiple lesion, refracture sometime can be the complications, and you have to look at that, and you might pick a pars fracture which may be there, associated pars fracture, or if it's metastatic ones, or if it's infection like Pott's spine is very common in India, and you don't feel infections, fractures, especially the Pott fracture. You treat the Potts first and think about it, and by the time Potts is taken care, the fracture is healed. Now choose your patient rightly. Somebody did a very good cementing block in here in the middle of the whole body, and look at the pedicles. Pedicles are totally shattered, absolutely gone, and this patient can't even sit now. So it's not advisable to do a cementing with a bilateral pedicle gone like this, unless it's really imperative that patient can't go for a surgery. And thanks for my friends who left this to me. Now this is what exactly is the philosophy. It's a cadaver bone philosophy of the vertebroplasty. Two things: you get into the right spot anteriorly in anterior vertebral body without breaching the medial border of the pedicle. May it be a single needle, may it be a double needle, depends what you really need to do. And the idea is you can go across, you go more laterally, and without breaching this one, you can go across with a single needle. That is what you have to learn. And always remember, the pedicle trajectory is so important. Dr. Pankaj talked about it and very nicely. You don't always have to go like this, because in thoracic vertebra, it's a downsloping pedicle. But if you keep doing it in flattened ones, you may go across. I'll show you another picture like this. And if you start going in a vertebral plana like this, or the low height vertebra, and you start going like this, you always draw a line. As soon as you start, you draw a line where exactly it is going. And when it's gone and it's touching the lower border of the vertebra, and now you start filling a cement in, your anterior column is totally left alone, and that's not wise and advised, right? So this is very important, because your anterior column is still collapsing, it will still collapse further on, and you have only small smooth. So this is very important. In these scenarios, you start low in the pedicle. You don't start high in the pedicle. Low in the pedicle, and draw a line. As soon as you start, draw a line where you want to go, and what is it? This is the narrowest zone of the vertebral body, and you have to cross this without breaching the upper and lower cortex or end plates, and you just go in there and then you fill the cement as much you can safely. That's the word. Safely is more important. It's always said underfilling is better than the overfilling. Remember this word for novice people who are starting it. And you're giving a fragment which is kind of a stable, but yes, these days this kyphoplasty is already on, so I would like to do a kyphoplasty than plain vertebroplasty. Now this is important slide. When you're doing this pedicle, why we talk so much about pedicle? We start upper outer quadrant here because you want to stay away from the medial border of the pedicle, because it is next to the nerve and neurostructures, and that is why we start upper outer quadrant. And another point which I'll give you, try to bring pedicle to the vertebral body. See, this is vertebral body, and you try to bring it, then just keeping it to one corner. It all depends what kind of fracture you're meeting and which end is a fracture, upper or lower level fracture. Accordingly, you bring this pedicle. This is a very big lead actually, then it becomes simpler. And this is what I was talking. When the pedicle is gone and you are trying to kind of put in a cement there, if your cement comes in here, it's a hell. So please understand, this is a very, very important philosophy, why we have to kind of save the medial border pedicle. And this is what normally we say, we have this kind of a check status, and then we kind of go in from 3 to 2 to 1 and avoid the medial border pedicle. And this you do virtually when you're doing on an image, and you do it there. But there may be situation you want to go more other side, then you have to start a little further off, maybe parapedicular, or you can start from here. So this is what exactly is important. Now this slide really shows when you're looking at this needle, in the AP view, it is just medial to the lateral border, and in lateral view is just behind the anterior margin, but it is cross the cortex. So please understand, when you're putting a needle from here to here and going across, you may be going across like this, and then again still you're looking. So this is very, very important that you orient yourself to this kind of philosophy, because it's a spherical thing. It's a roundish thing, not a straight square kind of thing. Use bevel to the navigate. Very beautifully said, and Pankaj, one of the slide, and we use it to avoid any breaches into the cortex, and then thread it over the K-wire. I normally put a K-wire first if it is a difficult fracture. If it's easy fracture, straight away go with the needle, vertebroplasty needle. Go anterior, 1/4 of the cortical margin. Avoid going too anteriorly because you might be going sidewise, and then you put a needle over the guide wire. There may be situations where you have to change a needle, maybe because the cement got clogged inside the needle, or you have done a biopsy with the needle and you have taken the biopsy out and you want to put the needle back in. Now these are few leads. If you want, you can put in a K-wire through the same needle, put a K-wire and use another needle over the K-wire, or guide wire for that matter, or you make a oblique view and you see the hole where you have gone out. Take your first needle out and put a second needle in there and simulate the one and keep that image intact there. With the latest navigation technique, this is the future. This is coming already. They are doing transpedicular screws in navigation way, and this is the newest latest thing. Now about the spinal fractures, this is where you tend to go in, and you see this facet nerve is lying here. Just because you've done a liberal local at the cortex here, and it does not mean you are not going to injure. You might injure one of these nerves. You be prepared to do a facet denervation, or maybe a kind of a block later on, maybe same sitting or another sitting. There may be situations when there is a root irritation, I told you earlier. You just do a root block, that's all. You don't really have to worry much. I tell you seriously, some patient does complain of radicular pain sometime, and just a root block is more than enough in these situations. Rarely would be a situation where you need to do something higher. Now treat all pain problems. I told you this slide earlier, and there's a fracture in here and this is here, and you look at this thing. This is again a symptomatic problem. So you have to treat both in there. There have been instances with the latest development. People are doing vertebroplasty and kyphoplasty endoscopic way. Now let me explain you what do I mean by that. Suppose there is a retropulse fragment. Suppose there is a compression coming into the canal or canal stenosis. They are removing the canal stenosis and canal decompression with the endoscope and doing a cementing in the vertebroplasty way. Same will hold true when the cement leaks into the canal. For some reason, you can manage endoscopically if you are good at it, and you do it very quickly before it hardens. Now this is what we are saying. There's some papers there. New technique that particularly is endoscopic decompression vertebroplasty in patients with osteoporotic vertebral fractures, and this is important in thoracic region. Please understand, in thoracic vertebra where sometimes fractures are there, the pedicles are more straight edge, they're more narrow, and when you try to go across, either you breach the medial border, which you don't want to, because the cord is thick here. There's no scope of pressing the cord. And in lumbar, yes, there is still a CSF kind of a space there. And you, when you tend to go across, you may not go across, you cannot do a global fill. Either you do a bipedicular or you do across, like effective pedicle is there, and you go more oblique like this, and you can go across without going through this. Now this is what I do. I put in a K-wire. This is D5 and D6 fracture. Look at this, K-wire first, and over the K-wire put in my needle there. But remembering, when you're putting the needle there, sometime it has happened in once, it is about 8-10 years back, this K-wire keep getting pushed across, and it's about an inch ahead, and there is all kind of things there, aorta, IVC, heart, lung, everything is there. You have to be very careful with the tip. So what you do is, when you change your needle over this, you put a blunt tip wire there instead of sharp tip wire there. This is a traumatic fracture. You do underfill, I told you earlier. Don't let it come out, and do only in a kind of a polytrauma scenario or emergency scenario. You don't do traumatic fractures normally, although there are some papers now which are saying you can do cementing in traumatic fractures, especially with some osteoporotic setting. But yes, it is what's to be done, and this is important to understand, that you don't kind of give a leak there. This is, I was telling you, the D5, D6, and you don't go from the same side. Please understand, friends. If you start going from same side, I'll show you next slide, there will be a needle fight, and then you have a nice global fill there. And this is what it is. This is a 6 level fractures, and patient had a 1 level fracture, didn't go for cementing, had a 6 level fracture, and I did all 6 in one go in 2010. And this was a world record at that point of time, 2010. Why we do multiple of them in one go? Because of the marrow which is there, bone marrow, it gets embolized into central circulation, and patient gets a big problem, or fat embolism. There has been a death also. I show you the next slide.
So we have 6 minutes to wrap up this session. We have to start into the next at 2 o'clock.
Okay. That's why I was asking, short or long. Anyway, I'll try to do as much I can, and then I'll stop it somewhere in midway.
Sure, sir.
Yeah. And this is what it was. The needle fight was saying that we don't want needles to fight with each other. You aspirate the bone marrow like this, and then you go start putting cement. There has been a death, I told you, because cement is lying here, is a marrow which has gone out, and there has been a death because of the fat embolism. Whether you do venography or not, because once you put a dye, it blackens the vertebra, and then you don't see the thing. You wash the vertebra then, and this I was told you, pulmonary embolism. And these are benign cement leaks. Cement may leak into any wall, interior, sidewise, into disc canal, or right or left lateral. No, my worry is if it shouldn't come into spinal canal or get into central circulation. And that is what as soon as cement start leaking, you give it a time to heal and harden in there, and then you start putting more cement in there. And that's what the normal philosophy. This has been talked beautifully by Pankaj. Another thing is lardoplasty. You're doing kyphoplasty ballooning, and suddenly, when you take the balloon out, again it collapses. So you do extension, as this is what extension and the traction is done to kind of keep the anterior column decompressed. And that is malignant leak is there. I was telling you about the endoscopic part. Some people are doing it, or be ready for the decompression. Paraplegia has happened. There have been a few complications with the IVC syndrome. There have been a life-threatening cardiac complication with the balloon kyphoplasty, and then you have all those things coming, cement dislodgements, and then root and spinal cord compression. But if you are very careful while injecting cement, nothing happens. Remember, this is what was been talked was vesselplasty, putting cement inside the vessel and leave the vessel there, because there are some holes, multiple holes, so it kind of hold well with the bone there, and spread it. And this is what was been talked. When you're trying to put a cement here, the tumor might get pushed back, and nicely talked, by the way. The complication part is only 1.4% in about 884 patients, asymptomatic pulmonary embolism, and only 0.7% will have a root irritation, which can be managed with the steroid shot. Yes, do it under local or general or neurolet, that is to be seen. Advantage of local is you have a feedback from the patient and you can go ahead. Keep your OT cool and keep your cement cool. Remember, keep your cement in the refrigerator and OT cool. Keep enough number of needles and all those gadgets ready with you, because you might have to go for something more. And idea is, when you start making cement, this is all time you have. When you start mixing cement, this is the working time you have with you, and you have to keep that in mind. As you start making cement in a cool bowl, cool saline, very important. In body 37 here is about 15-20 degree. It stays liquid for longer, and this differential temperature helps you. And this is what it is. With the radiopacification, you put in a dye. What I have done is, I did a presentation in the World Congress. I put in a dye and opacify the cement, because you don't get those very good radiopacified cement lately. Stop clock starts, and when you put in cement, always put in lateral live fluoroscope view only. Each drop has to go, 0.1 ml even has to go in the live fluoro view. You start from the interior border margin and keep going, and stop posteriorly, as Pankaj told, somewhere in there, and you don't have to go further on. Another important thing is try to have a interdigitation with the bone in here. If you have just a plain block, it might slip off, which has happened in some patients. If there's sometimes you see these cement nails in there, and this happens when you remove the needle too early and the liquid cement keeps flowing back, or you keep it too late because the cement inside the needle and inside the bone, they become one part and you take needle out and it starts giving you a bother. So this is about the quick fix phenomena. Stay away from the fracture and start filling in, because if you stay close to fracture, start feeding in, it starts moving away. But if it's non-osteoporotic, you start close to the fracture. This was the message. And this is the burst fracture, and this is a vertebra kind of thing, burst fracture, and you do a cementing in there and you see very good nice fill, even retropulse fragment has been taken care of. I'll explain you the lead for that. And this is another one which is the caught tethered, but it didn't do justice to the patient because the patient was painful in here, and I had to do a cementing for these vertebrae two levels, and pain was taken care. All those are very, very risky scenarios. Ever be vigilant. This patient came to me for the osteoporotic fracture collapse or vertebroplasty, and when I'm trying to do my procedure, I got another MRI done on the day, and you see this is a MATS, by the way. This is a MATS. This is a metastatic one. So the whole treatment changes. You have to send to for oncology unit, do a bone scan and find out more about it, and send for the oncological cancer treatment. But never ever forget your main target now becomes the pain relief, and you're doing intrathecal neurolysis in a lung cancer. And patient, he had a fracture of D3, by the way, 1, 2, 3, and I had to cement in there for the stabilization part. Yes, it has been talked, tumor ablation has been talked. I do it with my RF needles, but we have better techniques now. In kyphoplasty, this is a quick thing. It's empty bone syndrome. First, make a space for the balloon. Put in the balloon now. Hold the balloon in place. That's more important. And when you inflate, you see the balloon keeps going places. So it's very, very important to know where the balloon is going and keep it in place, because the balloon got burst. There's some dye in here. Another balloon I put in. I'm trying to inflate. It is trying to go anterior, and suddenly this cross the anterior cortex. If you're trying to put in cement there, it is going to go away. So one has to understand this. Very, very important to keep the balloon in place. There may be situations, surprises. Then you're trying to inflate balloon, it's not opening up. Don't you worry, because if you overdo it, it bursts. So you have to be very careful. Yes, there are pleasant scenarios. Then you have whole thing cavitation made, and then you kind of fill in. And once you fill in, remember, you fill the kyphoplasty little harder cement which stands out of this injector device instead of just flowy. You don't put a flowy cement in the hemangiomas and the kyphoplasty, because the cavity is there. You just have to fill the cavity. Take harder cement, don't take flowy cement, because it starts leaking away, and that's where you do it. This is another very good case lately. The patient has been fixed all over. You can see 6 level, and there's a non-union with the Kumbhal's osteonecrosis, avascular thing, and got a scan done. He was in a very big pain, so I put in a balloon in there, and a single balloon going away from the rod. This is very, very important, how to kind of take charge of this going away from the rod and then get inside there. And doing a paravertebral block for pain relief, which was just been talked. You have to do a pain relief in these scenarios, and this is what was there. Just see, this was the open surgery, and this is our incision, the vertebroplasty incision or kyphoplasty for that matter. And this is the patient very, very next day, the very happy patient. There may be scenarios you can't do with a single balloon. You do put a double balloon, never mind, but rarely you need double balloon. Last few slides now. This is another osteoporotic fracture with the vacuum phenomenon, but the cord at risk, here, or for the matter in the metastatic one, cord at risk here. And what I have devised my own way is, I put in a balloon from 1 or 2 spaces below and go to the fracture area and just put a balloon in the anterobular space, just in the behind the posterior cortex, and kind of safe the retropulsion, avoid the retropulsion, and kind of have a visualized thing what is happening in the inflation. When I do kyphon inflation, I see my balloon is visualized in there. And when I put my cement again, I have a visualized cement filling in there. And at the end of the procedure, I take this balloon out and do a myelogram, and see myelogram is doing so well. So I am able to do so many dirty fractures with the same philosophy, which was impossible otherwise. And this is the vertebra plana just been shown. Obviously, you cannot think of doing without kind of causing a further cord injury compression, and that is what we did with our balloon technique. I just showed you a minute back, because positive time I'm not showing you. And this is what the stabilized one. I'll show you this picture, by the way. The vertebral plana, 2 disc, kissing disc you can call it for the matter, and there's no bone in here. And this is the vertebral reconstruction. It's not a vertebroplasty, it's a vertebral reconstruction. You have a segment, loading segment now there, which can take the load. The flexion, you see sagittal deformity is corrected in many ways, and patient is pain free. So this was NJ dual balloon technique, and we just have a balloon inside and balloon outside. Only then it's possible to manage these kind of dirty fractures. And you have a safety balloon in there. Now you fit inside, safety balloon is out, and then you can count your blessings. And these are old patients who cannot go for a surgical correction otherwise, which you tend to tell them to do. And this is what epidural balloon neuroplasty and foraminoplasty, an innovation which I presented in the World Congress of Minimally Spine Surgery in Jeju Island, South Korea in 16 on the balloon. Last 3 slides. This is about the sacroplasty. We have been doing under X-ray guidance, but there's a very big risk of spilling the semen onto the neural foraminas. So what we do is a dual technique. We take patient to the CT under the floor guidance, put the needle in there, take the patient to CT room and put my cement in there. Because then you really see where the cement, each drop is going, because you have to avoid this neural structures there, which you really should not be doing in any case. Cervical vertebroplasty, thick wide bore needle. We are doing endoscopic procedures, cervical disc procedures. You can just simply go in there, put in a drops of cement. It stabilizes so well. It's a low volume bone, by the way. Same in C2 insufficiency fractures. Transoral, you going from anteriorly, it is like a tonsillar gag, and you just put a needle there and put a few drops of cement. So what has been rightly said in the beginning, prevention is any day better than cure, and especially when the disasters are like this, you better be having a prevention. And with the corona coming all around, everybody knows how much is the importance of prevention. And this cure really gives you a care to the patient and a happy patient at the end of it. And this is about the teaching is learning. I'll keep telling people we do training. My 17th workshop was due in April, which got victim to the corona. So maybe as and when. If there are any questions, if you have time, I'll be more than happy to answer. And well, anyway, the whole idea is pain relief is human right. Do it safe way, do it the right way, and do it in right spirit. That's more important. And I've been telling we are doing for our future generations. But here, when you say vertebroplasty, kyphoplasty, we are doing for our parents and grandparents. And thanks to my family, because who could spare me to spare time for all this. Thank you so much, friends. Thank you
so much, sir. That was such an elaborative talk, and we really are very, very thankful for that.